And next case is a case of globe catheter. We saw yesterday a case with the globe for linear lesion. Devi is going to show us some other applications for this catheter.
Thank you, Musa. So Vivek went over some of the features of the globe system, but I'll go over the features one more time, as this is an FDA-approved PFA system in the U.S. and has been launched, so many of you are not familiar with it, so I'll go over it one more time. So this is an array. It's not a balloon, so we'll start with that. It is a 30-millimeter heparin-coated array that has 122 densely spaced electrodes. They have about 1 to 2 millimeter spacing. The system can map, it can pace, and it can ablate, so it's a kind of one-in-all system. You have the capability of selecting the electrodes that you want to ablate through. It has high-fidelity thermal contact. We'll go over the details. And then the way the electrode sits is very different than some of the other systems or other catheters that we have. It is almost, it's unidirectional in a sense, so the energy application is shielded. So when you apply the energy, it goes towards the tissue and not towards the blood pool. So things like hemolysis don't become as much of a concern. It is a non-coaxial array, which means if you have a balloon that's over the wire, to deliver lesions, etc., you have to be coaxial, whereas this is a non-coaxial array, so you can sit in any axis over the vein, but just as long as you select the electrodes that's around the vein, you can deliver the energy in an antral fashion. It goes through a deflectable sheath, and it has a handle that is very stable and very responsive, so one-to-one transmission. The handle looks big, but you'll see as I'm doing the case, I'm literally barely holding on to it. To me, it's one of the true single-shot ablation systems where if you look at the Pulsar IDE trial and also the real-world data out there, most of the time we do one application per vein, and that is it. How do we assess contact? So it has two ways to assess contact. On the left here, what you're seeing is called flow map. Flow map is when you are assessing contact in a real-time fashion. So as you're navigating, you're looking on the globe, and what's seen as black is where there is, what's showing is the vein, and it measures the cooling of the electrode, so you can see that contact real time. Once you see that, you can go to what's called the contact scan. So when you do a contact scan, it's more precise. What happens is it measures the warming of each of the electrodes after a certain amount of current is delivered, and then looks at what the contact is. So this is more precise, and here you can see the white is where the contact is, and then right here you can see the vein that's being depicted. Of course, just because you have contact all over doesn't mean that you have to ablate the whole thing. You can select exactly whichever electrodes you want to ablate.
Devi?
Yes.
I'm not sure this is working.
It's on. Can we have?
Is it on?
It's on.
Okay. Yeah. Okay. Yeah. This is a very unique way of looking at contact, and as you said, you have the flow map, which is looking at a cooling phenomenon, and then you have the contact map, which is looking at a heating phenomenon. Are you still using both, or are you just going with the flow map, or what are you?
So I navigate with the array, and you'll see in the case, I go with the flow map, and once I see I'm by the vein, which I can see usually on ice, but it's really nice to see that correlation.
Yeah.
And I can see the coaxiality, because you can select your electrodes. So if I want to be more anteriorly biased, if I'm just planning a PVI, then I want my flow map to kind of look in that direction. And once I have that, then I'll run the contact scan, which usually takes a few seconds. So once I have contact scan, then I know I'm in a good shape. But I usually use the flow map as I'm navigating, and then the contact scan before I deliver my application.
And this catheter, I mean, I've used it, so I know the answer. But you don't push it inside the vein, right? So no. It's different from the Sphere 360 concept, right?
That's correct. It is an array that sits just on the antrum of the vein and delivers the lesion along the antral aspect. And there's different ways of looking at it. It has an integrated mapping system. So you can see there's obviously the map that you can see, the array and the map. And these tubes that are drawn are kind of what I call fake tubes. You're not going inside the vein to create that shell. Once you see the vein on the flow map, the system kind of gives you these tubes so you can kind of follow through. You can also look at the array for the map. So you can actually see the contact. You can get your electrode selection on the array. You can see voltage on the array. And you can see all of this in the map as well. So you have multiple ways of looking at the system, which I think is really unique as well. And the way I do, as Atul was saying, my workflow before ablation is to do that flow map, stop once I see that flow, and this is kind of what you will see, stop and see the contact. Once I have contact, I'll look at the voltage. You can see the voltage on the array. You can see the electrograms. I'm going to pause.
Oh, yeah. Thanks. I was wondering how much of an effort is required in doing the selection of the electrodes, and do you just select the electrodes, and then how many electrodes should you select, and then how much do you also select the voltage level and like anything else?
Yep, I'm getting to that one.
All right.
I will make sure I answer that. So, and of course, after deliver the ablation, you can see the electrodes that are selected. You can actually go back and do a contact scan to make sure you had contact and it didn't move. Now, obviously, I'm doing my cases under general, so I'm not worried. But if there was a question, you could always validate it by going back and running that contact scan one more time. You can see the voltage, and then, of course, you can see the EGMs. It also has another way of looking at these 2D maps, which I think, especially if you're doing PVI plus strategies, it's a real cool way of looking at the left atrium in a two-dimensional plane, because it lets you kind of see some of the activation, some propagation. You can almost kind of think about these being the veins, and you're looking from the mitral. So asking about the electrodes, you can select anywhere from 2 to 64 electrodes, and depending on what you want to do. So if you're thinking about doing a circumferential ablation, you can select just the system automatically will select the electrodes that is in contact. You can turn the ones that you don't want off. Most of the time, I'm customizing it based off of, it takes about maybe 2-3 seconds at most to customize it, because most of the time the system is pretty good at selecting the ones that are in contact, and then usually you're adding some or taking some away. You can do area ablation, so you can take the whole part that's in contact. You can do linear lines like Dr. Reddy showed yesterday, whether it's the right or the left atrium. So I'm going to quickly go over this case. This is edited, so you can see this is an 18 French deflectable sheet, so I'm doing a direct, doing an RF wire through the sheet. I tend to do an inferior kind of anterior stick, just because it kind of helps me maneuver, especially going to the right inferior. The array kind of has this bidirectional feature, so it kind of falls in. So you don't really have to, hook it into the right inferior vein or anything. You can kind of make it just rotate and pull down, and it'll sit on top of the right inferior vein in a non-coaxial way, and you'll get what you need out of it. So I'll just, as I said, I routinely put my ice in the left atrium. You can see the array coming out. I don't have fluoroscopic images, but I think Dr. Reddy showed them yesterday. But you can see how the array kind of comes out. And once the array is out, I'll make sure that, I'll move it back and forth. You can see I'm moving it back and forth. I'll clock and counterclock it. Just make sure I'm not entangled, but I can see it very well in ice as well. And once that's done, I'll rotate that knob that deploys the whole array. And once the array is deployed, now we're ready to move the system around. And you can see, you can create a full map before, or you can just go map and ablate as you're going. And here you'll see, so just to orient everyone, this is where you see the map, and this is where you see the globe map, or how I look at the globe map. So Atul, we're looking at the flow map here. So as I'm moving, I can see the flow map. I knew I was in a good spot. Now I'm going on contact scan. You can see the voltage and you can see the contact. And at that point, it automatically, you can see right here, it's selecting the electrode. It's a click of a button and it selects the electrode. Now this was a patient that had persistent AF, older patient that had heart failure. So we were thinking of a more PVI and posterior wall strategy. So you can see I'm very generous with my electrode selection here. And what you see here is the electrodes that I've selected, I can see on my map as well. I can see how posterior I am or how anterior I am, and I can take them off if I need to. I just wanted to show this one time where I did the lesion, and I came back and did the contact scan one more time, just to show you that you can see where those little pink shade that you're seeing is where I ablated, and the contact scan looks exactly like the way it was. And somewhere along the way, you'll notice it's not like I'm holding this thing hard on or anything. It's literally barely holding on. I think it takes more effort to hold the ice in place than holding the system in place, in my mind. So, and I'll let this play along, but here you can see I just pulled it down into the left inferior. There's really not a deflection. You're coming from the left superior and just kind of dragging it down. And you can see on the map, it kind of shows that. You can see the electrode selection. And what I like is you can see where your previous ablation lesions were. So you can get that overlap. You can get that anterior carina. You can be very prescriptive about where your ablation is going to land, which I think I like. It's one of the features that I like the most in this system.
Devi, one of the slides you showed earlier, I may have seen a flutter. Did you show a flutter or some atypical arrhythmia?
Yep, so that's one of the reasons we decided, the patient had a history of it too, or atypical flutter, so one of the reasons we decided to do the posterior wall as well. We did, again, the plan was to induce if we needed to, and do mitral if we needed to, which you can.
So the question is, how is the experience with you or other folks who use this catheter with mapping atypical flutters or for redo procedures or any procedure other than first-time PVI?
Oh, yeah, you can easily. The mapping is very, it's a high-density mapping solution in my mind. As I said, you get those nice 2D waves, but you also get a pretty good activation map. And then once you identify the isthmus or wherever you think it is, you can actually see the entire circuit on the array when you put it by the circuit, which is kind of really neat to see. And then once you say, if you do a linear line, you can see block within the array. Just you don't have to pace on both sides. You'll actually see the activation block on the array, which is also pretty cool in my mind. So here you can see I finished the right superior. And to get to the right inferior, I'm literally just pulling it down and counterclocking it. And I'll watch on that on the map here, and I'll watch on my array map when I see that flow map. And it's starting to open up the right inferior vein right there. And once I see it, I'll pause, I'll get my contact scan, and you can see I've got great contact around the vein. And you can see how quickly they'll select the electrodes. It's pretty much a click of the button. So the mapper will go right there and convert it into the electrodes that are being selected. As I said, this is a very generous lesion set because we were planning on doing a posterior wall in this case. And what I also want to show, I'm going to move on from the right inferior here, how easy it is to do an area ablation as well. So in this case, I just counterclocked it, brought it back into the posterior wall. What I want you to notice is the voltage on the array. So you can clearly see where you had your previous lesion tags and where the voltage is. You can see the normal voltage along the floor of the left atrium. You can see there's some amount of stunning, obviously, but once we have contact there, we'll go ahead and select that area so you can see the contact. It's kind of hard to see, but once I select it, I can see exactly where those electrodes are falling. And so if I did want to take this down, I can, but you can see it's in a good orientation. So I go on with the lesion, takes about somewhere up to 40 seconds for it to go through its cycle. It's usually, so you could, in the posterior wall, you could do half dose. So especially in the inferior aspect of the posterior wall, I would do what's called a half dose, which is also shown to be very durable. But on the roof, I know it's much thicker tissue, so I do the full dose. So you can customize the energy delivery as well if you wanted to. I know there is work being done to look at if half dose is all you need everywhere. But right now, this is what I do.
Devi, can you go back to, I think it was, you had a nice view of the signals at one point, because I wanted to talk a little bit about the signals, because these electrodes are a little bit unusual, right? They're printed, larger gold electrodes. And so when I first saw it, I thought, oh, you know, you're not going to get very good signal fidelity. You're going to see a lot of far field. But there was one point where you showed a close-up of the signals. But anyway, you can sort of see them down there. You know, they actually don't show a lot of far field, which is interesting. They, you know, it's very much a near field signal. But what you use for your ranges of normal versus scar are a little bit different based on a traditional, you know, let's say octaray mapping catheter or something like that.
Yep, I agree. So you can see we're kind of, you know, we did one lesion per vein, and we're doing the posterior wall here. And again, it's an area lesion, so there's a selection of the electrodes, one click. And sometimes you'll see some electrodes that you don't want, and you can take them out. And then once that is highlighted, you can see where that goes. And in this case, it was pretty much 4 lesions, you know, 1 per vein and 2 for the posterior wall, and we were done. This is just using the array. We're creating the map. Now, we're not used to seeing maps like this because it's a very kind of, I would say, global map, but the concept is still the same. I mean, it's still a high-density map. Again, coming back to activation, I think you can see the same thing pretty well in this case. Now, while questions are being asked, I'm just going to show a PVI-only case. I'll let it run. It's pretty intuitive. Just
Devi, can you remind us of the study results? You had excellent durability. I think you had even better freedom of AF.
That's correct.
Expected from durability. So that's my first question. Can you hypothesize on the beyond durability effect? And can you reassure us on the brain findings? Because at the end, it always looks like a bulky device, and you feel there might be concerns with the big transeptal puncture device.
So I'll put that up since we are, hold on, there you go. I knew you were going to ask me, just kidding.
Yeah, sure.
No, so it was, I will say that the Pulsar ID trial probably had, you know, I mean, it has great safety. You saw that. There were no device-related safety events. There was actually, I think, Atul, correct me if I'm wrong, but I think there was one hemorrhagic stroke in the study, but that was the only complication that was there. There was not even a vascular injury, even though the sheath is like 18 French. And you can see the 12-month success rates were 78%. And the durability, now this is in the redo population when the patients came back. 39 out of the 41 veins, when these patients came back with clinical arrhythmia recurrence, and there was 95% durability in that high, you know, I would say a very small population. That's the high yield population.
And was there systematic brain imaging?
There was. Atul, do you remember the data? It was good, is what I remember.
Yeah, no, it's very consistent with any other PFA device. So it's kind of in that, you know, 10% range. It's definitely not higher. I would have shared your concern as well. You know, it's a large device, large sheath. But actually, as it turns out, the SCE is very compatible with any other PFA catheter out there.
We have, Devi, we have one question from the floor.
Hi, thank you. Just 2 clarifications. I've seen during your case that when the electrodes are selected, they become, you know, green or something. But then sometimes some of them turn yellow. So can you comment on that? And the second, you said that up to 46 electrodes can be selected.
64.
64. Can you comment on the duration of the train or the application? Because you mentioned at 1.40 seconds. Is this dependent on the number of
So it's not dependent on the number of electrodes. It's 6 trains. It just takes about 30 to 40 seconds. And I missed the other question. No, so the orange is, so you have to have pairs selected. So sometimes it'll kind of give you the orange, so it'll give you the option of deselecting some to get you a green. So it's kind of creating that, the right pairing of the electrodes is all it is. But it's pretty quick as well to take it out if you don't want it.
So we have 30 seconds, so a quick question and a quick answer.
When you're deploying this for the first time, are you worried in smaller atria? Just how do you decide what's the right place to open up that big balloon?
Yeah, so I mean, remember it's about this a little bigger or about the same size as a cryo balloon. So when I'm bringing it in, usually I'm unsheathing it in the middle of the atrium, usually a little bit where I can see the left superior pulmonary vein on ice. So that's usually the angle I take, which means as it comes out, it's not coming onto the mitral valve or something. So I take the deflection off, keep it in the mid atrium, and then just kind of come out. And it curves itself inward, so it's unlikely that it will go and tangle on anything.
Another very nice case. Thank you, Devi. And our next